Hello again. This is Dr. Rockhold, and I welcome you to the first of 4 segments on antidepressant pharmacology. As the title cartoon suggests, the use of pharmacology to alter mood is embedded deeply in the human psyche, and it's particularly relevant to us in the United States. We'll learn as we go forward that while clinical depression is ancient in origin, the use of prescription medications specifically to improve symptoms of major depressive disease, or MDD, has occurred only relatively recently. Overall, these 4 segments will introduce how we think the major antidepressant agents act in management of unipolar MDD. While some of these also are used in treating bipolar depression and other clinical problems, we will focus on MDD therapy. As we go forward, we'll discuss 6 major groupings: the monoamine oxidase inhibitors, the tricyclic antidepressants, the selective serotonin reuptake inhibitors, or SSRIs, the serotonin norepinephrine reuptake inhibitors, SNRIs, the serotonin modulators and stimulators, SMSs, and atypical antidepressants. We'll also introduce examples of very new rapidly acting antidepressants. You will need to be able to classify these by general mechanism of action and by major or unique adverse effect profiles. I should note also that recognize that the classification groups are under active review and the titles and groupings of these various drugs could change in the future. And then finally, I will include with this material links to 2 ancillary topics on the serotonin syndrome and a highly relevant piece of medical history. As you're learning in this topic block, major depressive disease is significant in its individual and in its societal impact. Dr. Paul and the other lecturers will introduce you to the signs and symptoms of major depressive disease and also indicate a variety of diagnostic tools that will be at your disposal. Of these, the fast and simple patient health questionnaire, or PHQ-9, is one that is very commonly used and you should be aware of. The next 2 slides are going to help us frame the significance of this problem. In this slide, from a very recent article in The Lancet Psychiatry, we recognize that globally, the United States ranks very poorly, both in the prevalence of mental disorders and in the per capita consumption of psychotropic medications. Major depression and antidepressant drugs constitute major components to both these indices. If we look more closely at antidepressant medications, the statistics become particularly concerning. 2 years ago, when I last gave this lecture, about 1 in 10 Americans were prescribed an antidepressant. That has escalated alarmingly, and now 1 in 8 are taking at least one of these medications. More women than men use the drugs, and use tends to increase with age. Finally, it's interesting that fewer than a third of those receiving a prescription for a single antidepressant, as opposed to taking more than one antidepressant, fewer than a third have been seen by a mental health professional in the past year. This may suggest overprescription of antidepressants by other healthcare professionals and is a cause for some concern. So, to put these introductory remarks into some perspective, you'll need to recognize that while we will focus primarily on their use in MDD, antidepressant agents have a host of indications beyond major depressive disease and specifically include use in a variety of anxiety states. We'll talk more about anxiolytic agents in a later sequence. If you'll look at the graph in the upper right, recognize that while newer agents, the SSRIs, the SNRIs, and the so-called atypical agents comprise about 2/3 of prescriptions. The older agents, the tricyclic antidepressants and the MAO inhibitors, are still rather frequently prescribed. You need to recognize distinctly that individualization of therapy is essential for proper management of major depressive disease, and drug choice is determined in any individual patient by that patient's past response to drug agents, by their tolerance of the side effect profile of the drug or drugs they're taking, and these can often be significant, and by the potential for drug-to-drug interactions with any other pharmacology regimen that the patient may be enduring. It's also important to recognize that in MDD, treatment to effect may require both patience and a willingness to trial more than one agent. It's not enough for the patient to just be feeling better than they were at the start of treatment. The goal is to return to pre-episode mood and function. There is a 3 strikes rule that says that for an initial episode, treat to remission and maintain for at least 6 months before tapering off and seeing if the patient is doing better. If a second episode occurs, put that patient back into remission and maintain them for 12 to 18 months before again tapering. And then for any third episode, treat as if this is a chronic condition and maintain prophylactic treatment indefinitely. Don't get complacent by a continued positive effect of the drugs that you are giving. And then finally, you need to recognize that all antidepressant agents are required by the FDA to carry a black box warning. Paradoxically, there is a risk of exacerbating suicidal ideation and behavior associated with the use of antidepressant medications.